This is a global initiative for asthma. Their organization, they give guidelines regularly, and it will be useful if we go according to this guideline. And you can also refer the book how they are dealing. These slide sets are good, so I thought maybe I will teach these slide sets. Okay, so first is burden of asthma. So one of the most common chronic diseases worldwide, and we have more than 300 million affected individuals. So the problem is a big problem, asthma. So almost like 10% in many countries are affected by asthma. So it is increasing in many countries, especially in children, resulting in school and work absence, and health expenditure is also high. And looking at the burden, the developed countries like America, Australia, it is more than 10%, and for India and Asian countries, it's around 5%. Okay. So definition and diagnosis of asthma. So, so the main characteristic feature, the pathogenesis is chronic airway inflammation. So anything you want to know one word, it is chronic airway inflammation. So there is a chronic airway inflammation going on, and this results in bronchoconstriction. And the bronchoconstriction presents as wheezing, shortness of breath, chest tightness, and cough. So these are the symptomatology. So they present with wheezing, cough, shortness of breath, chest tightness. And the most important characteristic feature is this bronchoconstriction is varies in frequency. The episodes may not be the same. The bronchoconstriction will not be the same throughout the year. It varies in frequency. It varies in intensity, and variable expiratory airflow limitation. So the main point to understand it, the bronchoconstriction and expiratory airflow limitation is variable. So it's variable over a period of time, over a period of day, and variable with medications. So that is the characteristic feature. So reversible bronchoconstriction. So there will be chronic airway inflammation resulting in symptoms, and these symptoms are because of bronchoconstriction. And the bronchoconstriction is quite variable. It varies with day, it varies with seasons, and it varies with medication. So the two defining features for asthma is history of respiratory symptoms, which we suggested earlier: wheeze, shortness of breath, chest tightness, and cough. And most important will be the bronchoconstriction is variable expiratory airflow limitation. So the expiratory airflow is limited in a variable manner. It changes dynamically. So if there is any algorithm, how will you manage asthma? So you ask for symptoms. Are there any symptoms like the already mentioned? Are there symptoms of asthma? Yes. Then go for a detailed history and examination. Is the detailed history and examination supporting the diagnosis of asthma? Yes. Then go for the objective spirometry. So you go for the objective spirometry, and in the spirometry you also have this reversibility test. You give bronchodilators and see whether the pulmonary function tests are improving. So you have to document decreased pulmonary function tests, obstructive pattern, and also you have to demonstrate the reversibility. After giving the bronchodilators, it should be reversible. That supports the diagnosis. And finally you treat for asthma and see whether the response is there. Okay. So if your history suggests anything other than other diagnosis, try to work out as the alternative diagnosis. And if you are not responding to treatment for asthma, you are not, the patient is not responding to bronchodilators, then again you try to evaluate for the alternative diagnosis. So what are the symptoms that increases the probability of asthma? So sometimes, especially in children less than 5 years, we cannot prove exactly. The children cannot do spirometry. Less than 5 years, they don't do spirometry. So we can only just say that there is a probability of asthma based on symptoms. So it should be more than one symptom, like wheeze, shortness of breath, cough, and chest tightness. We said already. Symptoms, I said they change in intensity. So mostly it will be nocturnal. So symptoms worse at night or in the early morning. Symptoms vary over time and in intensity. So during the winter season, children have more symptoms. So symptoms over a period, over time or seasons, and symptoms triggered by some. There should be some trigger, like in children, viral infection. For adults, it could be exercise. It could be allergen exposure. It could be changes in weather or irritants such as car exhaust fumes, smoke, or strong smells. So any of these can trigger the diagnosis of can trigger asthma. Okay. So coming to the most important objective. So once your history is present, history of the symptoms which I said already, then you go for the spirometry. So spirometry is basically it gives an objective evidence that how the pulmonary function is it obstructive, and finally you go for whether it is reversible or not. So you ask the patient to blow with your after taking a deep inspiration, blow with full force whatever you could expire. So the full force expiration, whatever volume you get, that is called the forced vital capacity. Total volume which you expire is your forced vital capacity, and you are going to also check how much you are able to expire in 1 second. So that is forced expiratory volume in 1 second. So usually in asthmatics, because of the broncho obstruction, the forced expiratory volume in 1 second is going to be less. It is going to be reduced. The volume which you expire forcefully in 1 second is going to be less because of the bronchoconstriction. I will come to that later. And one more instrument you should know is your peak flow meter. Peak flow meter is something, it's a handheld device. It is meant for the patients to monitor themselves whether their pulmonary function test is worsening or improving. It is nothing but you blow heavily in this instrument with full force and see the maximum flow. So that is the peak expiratory flow. Suppose the flow is 350, next day it is 450, and after some days it's regularly around the 450, and suddenly it reduces to 250, which means that he has worsened. So it's a way of monitoring his own pulmonary function test on a day-to-day basis. This is peak flow meter. Okay. Any doubts? You can raise your hands, ma. So maybe in between I will pause and discuss. Okay. Okay. So the most important objective evidence, I said the pulmonary function test. The important parameter I said is forced vital capacity, which is the amount of air you are going to exhale totally after a forced inspiration. Then you are going to record how much you are able to exhale in a single second. You are going to make a ratio forced expiratory volume in 1 second by forced vital capacity. Usually the ratio will be around 0.8 in healthy adults, and in children it is like 0.9 in children, which means that of the total 100%, 90% of the volume is exhaled in 1 second normally. And in healthy adults, almost 80% of the total volume exhaled is exhaled in the 1 second. But in case of asthmatics, it's going to be less than the 80% margin. So it's going to be less than 0.8. And one more important is confirm the bronchodilator reversibility. So after giving a bronchodilator, make sure that the FEV1 improves by more than 12% or more than 200 ml. So increase of more than 12% after giving a bronchodilator of your pulmonary function test, it shows the reversibility in the pulmonary function test. That also suggests the diagnosis of asthma. And you can also go for the diurnal variability using the peak flow meter. So you keep recording morning, evening, the peak flow. If there is a significant variation in the peak flow monitoring, that also suggests that the child might be having asthma. The patient might be having asthma. And most of all, significant improvement in pulmonary function test after starting treatment also suggests that the child might be having asthma. Okay. Okay, so this is the important two spirometric tracing you should understand. So forced expiratory volume in 1 second in normal child is going to be high, and in asthma it is going to be less during the first second. And once you give a bronchodilator, it's going to improve. So this reversibility you have to document in spirometry before making a diagnosis of asthma. And most important, another curve which you might be given in any MCQ pattern is this flow volume curve. This is the normal loop. This is the expiration. This is the normal loop. And in asthmatics, there is a characteristic scalloping. So understand this scalloping. This characteristic scalloping happens in asthmatics. And after giving bronchodilator, the curve improves towards the normal. So remember this flow volume curve, remember the scalloping. And if you're shown a time-based scale, remember it's going to be less for asthma, it's going to improve after bronchodilator. And for normal children, the forced expiratory volume during 1 second, it's going to be high. Okay. And physical examination of adults or children, it's going to be normal except for wheezing on auscultation. Especially if you are doing a forced expiration, wheezing is going to be present. And also in severe asthma exacerbations, when totally it is bronchoconstricted, no air is flowing, then you might also not get any wheezing. It doesn't mean that the child doesn't have asthma. So silent chest in a sick child, a non-asthmatic, means it's a severe asthma exacerbation. Okay. And okay, so we will pause here. Any doubts till now? So we discussed about what is asthma, and we discussed about the reversibility part and how we are going to diagnose based on spirometry. The important parameter is FEV1 bar FVC, forced vital capacity. Okay, and remember the curves. And any doubts, you can raise your hands so that we will go with assessment, then treatment. Okay, step by step we can move.
Sir, in children, can asthma occur secondary to GERD?
So that is an important differential diagnosis. I will come back to the slides. Those are comorbidities. They are termed as comorbidities which can aggravate the asthma. Suppose the child has asthma, this GERD, then the allergic rhinitis and obesity, and all these can aggravate the asthma. Okay. And GERD as such can present symptomatology similar to asthma. So every time they aspirate, they will have this cough. During the night time, they will have the cough. So GERD as such is a mimic for asthma. Then one more is, suppose you are already having asthma, it can aggravate because the aspiration and all that's going to trigger your inflammation. But more of GERD is a differential diagnosis for asthma. They present symptoms very much similar to asthma. So you correct the GERD, the cough symptoms are going to improve. Okay.
Okay, sir.
Okay.
I didn't get the flow curve which you showed.
Napa?
So the flow curve which you showed, I didn't understand.
Flow curve,
Yes, sir.
wait, it's just you can go deep if spirometry, but you have to remember these two things.
Okay.
This is the volume which you are going to exhale, and this is the time taken to exhale that volume. So you are asking the patient to exhale forcefully. So we are looking at like how long the patient exhales. So it's like 2 minutes, 2 seconds, 3 seconds, 4 seconds, 5 seconds. You are asking the patient to exhale forcefully. And in that time,
Okay.
how much is the volume you are exhaling during the first second? So that is very important. During the first second. So
Okay.
during the first second, the volume which you exhale in a normal patient is going to be high. And in an asthmatic, in the first second, it's going to be less, obviously, because of the bronchoconstriction. And
Yes.
we have to document reversibility. Once you give a salbutamol inhaler puff, and then again check how much you are able to exhale forcefully in 1 second, it's going to improve. Although it's not going to reach the normal, it's going to improve. So this reversibility is very important for making a diagnosis of asthma. Okay.
Okay.
And this is the flow volume curve. This is the volume which you are exhaling, and this is the speed with which you are the speed with which you are exhaling. So
Okay.
obviously asthmatics, because of the restriction, they have this scalloping. They will not be able to have a good flow because of the bronchoconstriction. So they have this incurving while exhaling. So this is the asthma. And once you give bronchodilator, this scalloping slowly improves towards the normal. So this curve pattern is very important. They may just show you the curve and ask whether it is normal or whether it is abnormal. Okay. And
Okay. Thank you.
there is one more, your restrictive diseases like this fibrosis and all, where the flow itself will be less. So they will have a smaller curve. Instead of having this much big curve, they will have a smaller curve. The volume will be less. So they will have a very smaller curve in restrictive disorders, but they don't have this scalloping. Okay.
Okay. Thank you.
Thank you. Thank you. So assessment of asthma. So assessment, we need to assess what is the control, how much is the patient controlled, how much for the past 1 month, how much symptomatic he is. So assess the control, how much symptomatic is he is. So that is the control. Then assess risk factors. There is one concept that even though he is controlled, well controlled, suddenly he might have an exacerbation. Suddenly he might have a bad exacerbation. So he might have a very good control. Suddenly, suppose it's a Diwali time, crackers are there. Suddenly they have this exacerbation. So they have certain risk factors for the exacerbation. So here the Diwali cracker is an exacerbation. So there are certain risk factors where they have a higher chance of worsening, even though they are controlled for a period of time. So they might be controlled for 2-3 months. So we have to maintain control, but they do have risk factors to worsen at any point of time. So that risk factors also we have to assess and try to prevent those risk factors. Then we have to assess for comorbidities. There are comorbidities like, as we said, GERD and allergic rhinitis, obesity. So these are all comorbidities which are going to worsen asthma. However you treat asthma, if there is allergic rhinitis, if there is a postnasal drip, the wheezing symptoms are going to persist. So we have to address the allergic rhinitis also. And we have to assess the treatment issue. So you you diagnose it, you give the inhaler therapy, and the patient doesn't take it, then it's not going to work. You cannot keep on stepping up the treatment unless you have addressed the treatment issues. The patient should be taking the treatment correctly. No point in keeping on stepping up the treatment, and make sure that he is taking the medicines properly. So we have to assess the treatment issues. So we have to assess whether for the past 1 month or 2 months, how is his control. And we have to assess whether there are any risk factors which can cause exacerbation at any point of time. And we have to address the comorbidities like allergic rhinitis and GERD, etc. And we have to assess the treatment issues, whether he is compliant, whether his technique is good, and whether he is taking properly or not. Okay. So this is the first assessment of control. A well-controlled patient for the past 1 month should not have any nighttime symptoms, should not be using any relievers, and should have daytime symptoms less than twice per week, and should not have any activity limitation. So who is a well-controlled patient? He might be having asthma, but for the past 1 month, if he doesn't have any daytime symptoms for uh, more than twice a week, so he has only once or twice daytime symptoms per month. Actually, it's not per week. It's per week. Okay, so we'll keep it as per week. So if he doesn't have any daytime symptoms 2 times per week, If he doesn't need salbutamol more than 2 times per week, and he doesn't wake up in the night for the whole week, and he works normally, he doesn't have any activity limitation, then he is well controlled. Otherwise, he is partly controlled or uncontrolled. Avinash, can you repeat that? Very important 3 points, I think.
Yes, sir. Um, Based on the past 1 month, if the patient is experiencing symptoms, for example, daytime, if he's experiencing any of the asthma symptoms during the day, which is more than twice a week, or if he requires salbutamol or any of the drugs to relieve the symptoms more than twice in a week, or if he's waking up at night because of nocturnal symptoms anytime during the 1 month, or if his work is being limited or if it's being affected because of asthma, these are all one point. If he has none of these, then it's very well controlled. If he has one or two of these, then it's partly controlled, and if it's three or four, then it's uncontrolled.
Okay, ma'am. So it's too much taxing for you for a practitioner. It might be needed. So just remember, if in a week, if he doesn't have much of the daytime symptoms, much of the nighttime symptoms, doesn't need a reliever more than twice a week, he doesn't have any activity limitation, he's well controlled, and that should be our goal. He should be well controlled. And suppose he is partly controlled or uncontrolled, then we are going to check his technique, whether he is doing everything right or not, and we are going to step up the treatment. Suppose he is well controlled, he is doing well, then we are going to step down the treatment. So your step up treatment or step down treatment depends upon his asthma control. And what is asthma control is these 4 points you should remember. Okay, don't worry, I'll be sharing the slide set for you all. Okay, and then assessment of risk factors for poor asthma outcome. I said already that control is something different, but chances of getting worsening at any point of time is different. So if he has been intubated any time in the past, if he had any severe exacerbation in the past, if he has a low lung function test, his low FE, if he has low FEV1, and he is not taking the inhaler properly, or he is a known smoker, or now the lady is pregnant or obese, they're all risk factors for exacerbation to at any point of time. So he might be at control last month, previous month, but if he had an intubation, if he had a serious asthma in the past, if he still has a low lung function, or he is not compliant enough, he is a smoker, he is a pregnant, she is pregnant, then it's a risk factor for poor asthma outcome. Anytime he can get an exacerbation. So you should try to prevent this, try to improve the technique, try to stop smoking, try to reduce the weight, and other which you cannot prevent, just you have to wait. Okay. And as I said, comorbidities, you are asking, so GERD can worsen. Yes, so GERD, rhinosinusitis, allergic rhinitis, obesity, obstructive sleep apnea, pregnancy, all these comorbidities are known to worsen asthma. So unless you address these comorbidities, whatever treatment you do, the child may not respond to the asthmatic treatment. So you have to also address the allergic rhinitis. You have to also address the GERD. You have to also address the obesity. Okay, and make sure in Western they have this good protocol of having a written asthma action plan. Here it's less, but remember that there is something called written asthma action plan, where the patient should know what are the usual asthma medications. The patient should know what are the symptoms of worsening, and if there is worsening, how am I going to increase the medications, and how am I going to start oral corticosteroids, and when to access the hospital. So these all should be written in the asthma action plan. It's not like you start giving a treatment, continue the treatment, he worsens, he doesn't know whether he is worsening or not, he doesn't know when to come to the hospital, he doesn't know to add steroids, which can be very helpful, because steroids take at least 4 to 5 hours to work. Oral steroids are not going to act within 1 minute or 2 minutes. So if he takes in the night oral steroids, by morning he will be better. but if he doesn't know to take that, he might go into status asthmaticus and his life might be in danger. So having a written asthma action plan is very important. So now coming to treating the asthma to control the symptoms and minimize the risk. So far the previous section we said how to assess asthma. What does control means? What does control means? What are the comorbidities that can affect the asthma control? And what are the risk factors that can cause exacerbation anytime, any part of time? Okay. Any doubts at this point? I think it's fairly easy. So you have to just go through the slides again. So it's points are more, that's all. Okay, so now you know that what is control. How are you going to control? What medications are we going to treat? Okay. So there are two types of medications, very important. So one is controller medication and the other is reliever medication. Okay. Avinash, you know of controller medication?
Um, so, um,
Any example?
corticosteroids,
Corticosteroids. Reliever medication, any example?
bronchodilators, salbutamol,
Okay,
salmeterol.
very good. So almost we know the basics. Okay, controller is going to control the inflammation, and reliever is if it has exacerbation is there and it's a serious problem, it's going to relieve immediately. So the bronchodilator is going to relieve immediately. So controller and reliever, and there is no treatment. No, there is no treatment. So asthma cannot be cured. So what are the controller medications available? Just have a look at it. So one is inhaled corticosteroids. So the basic pillar of controller medication is inhaled corticosteroids. Then since there is a stepping up, so if low dose inhaled corticosteroid doesn't improve, you go for the medium dose, then high dose. But high dose corticosteroids are going to have some side effects. To avoid that, we are going to add inhaled corticosteroids along with long acting beta 2 agonists. So LABA, we call that as LABA. It is long acting beta 2 agonist. Salbutamol is a short acting beta 2 agonist. Long acting beta 2 agonists like formetrol, solmetrol, they're all long acting. Okay. You also have leukotriene antagonist, which is orally available, leukotriene antagonist, but it is less preferable. So the most important preferable controller medications are inhaled corticosteroids, and the second one is the long-acting beta-2 agonist, which has to be combined with inhaled corticosteroids, and it has a steroid-sparing effect. It reduces the dose of steroids that is needed, and you do give leukotriene antagonist. It's a orally available. Many people don't prefer inhaled. They have a huge problem in taking inhalers in India. They feel that it's going to be addictive. So you have no other option to give the next less preferred is your leukotriene modifiers like Montelukast. Okay. And recently there is an FDA warning for leukotriene antagonist that it has psychiatric problems. It causes psychiatric problems. So in adults, suicidal tendencies are also reported. So the only option which we often use in Indian scenario is Montelukast, and that has now an FDA warning that it causes psychiatric symptoms. So we should use it carefully. Better to go for inhaled corticosteroids. Okay. So what are the inhaled corticosteroids available? You have beclomethasone, you have budesonide, you have fluticasone, cyclosonide, triamcinolone. Okay. We are as pediatricians, we are we use budesonide and fluticasone quite often, but beclomethasone and cyclosonide are all common. Okay. They are the inhaled corticosteroids. Remember that there are three type of drug doses. One is the low dose inhaled corticosteroids. If doesn't respond, you go for the medium dose inhaled corticosteroids. If doesn't respond, you go for the high dose corticosteroids. So these are the micrograms equivalents, which you call that as low dose and medium dose. So for beclomethasone, it is 100 to 200. Like that for budesonide, fluticasone, and triamcinolone. So these are the low dose, medium dose, high dose. Similarly, for children also, you have one more bioequivalence for low dose, medium dose, high dose. Okay, no need to remember that. Just remember that there is low dose, medium dose, and high dose corticosteroids. Okay, and what are the long acting beta 2 agonists available? Formoterol, solmetrol. So the most important is the formoterol. So budesonide formoterol combination and fluticasone solmetrol combination. Okay, and what are the reliever medications available? So short acting beta 2 agonists like salbutamol is a reliever medication, and the another relieving medication we quite often use in ICU is the short acting anticholinergics. So anticholinergics like ipratropium, it is another reliever medication. And current guideline recently in 2019-2020, they are now using low dose inhaled corticosteroid along with formoterol as a So now the 2020 guidelines say that low dose inhaled corticosteroids and long acting beta 2 agonists, especially formoterol, can be used as a reliever medication. So now they don't recommend plain salbutamol as a reliever medication in adults. They always say that use low dose inhaled corticosteroids along with a long acting beta 2 agonist as a reliever medication instead of just beta 2 agonist. The reason behind is people often tend to use salbutamol even though their symptoms are very high. They just use only salbutamol, and evidence say that those who use only salbutamol have a high chance of getting admitted seriously in ICUs. So now the guidelines say that do not use salbutamol alone for as reliever medication. Always use some combination of steroids along with salbutamol. So now the recommendation is use low dose inhaled corticosteroids along with long acting beta 2 agonists as the reliever medication of choice. So this, if you have a take home of this point, then you are update with the GINA guidelines. So far the old school of thought is any wheezing, use salbutamol. So now the school of thought is do not use salbutamol alone. So use low dose inhaled corticosteroids along with formoterol, long acting beta 2 agonists. Okay, and okay, so the our main aim is to symptom control. So the recommendation for adults, adolescents, and children 6 to 11 years is do not wait much. Start controller treatment as early as possible, which is nothing but start your steroids, start your inhaled corticosteroids as early as possible. So your threshold should be very low. Do not say, okay, we'll wait for another 1 year, we'll wait for another 2 years. No, start your controller treatment as early as possible. It is going to reduce down your exacerbations. It's going to reduce down your admissions to the hospital. Okay, so when am I going to start with low dose inhaled corticosteroids? As we said, the based on the asthma control, if the patient is not in control, which means that asthma symptoms are more than waking up more than once a month, and asthma symptoms more than twice a month. So I think it's a month, more than twice a month, and more than once a month you start steroids. So whenever asthma symptoms are more than twice a month or waking due to asthma more than once a month, you are going to start low dose inhaled corticosteroids. And if you are going to have weekly symptoms, you are going to wake up weekly, or you are going to have troublesome symptoms on most of the days, you are going to use a higher dose of inhaled corticosteroids. I will show it in the flow chart so that it will be easier for you. So these are the steps, very important steps in management of asthma. So this is step 1, step 2, step 3, step 4, step 5. Okay, so step 1 is so you start with whenever the child has a wheezing, you start with low dose inhaled corticosteroids and formoterol. Okay, so this is a combination of low dose inhaled corticosteroids and formoterol. And step 2 is you are going to give daily dose. You are going to give daily the inhaled corticosteroids. And step 3 is you are going to add long-acting beta-2 agonists along with the inhaled corticosteroids, low-dose inhaled corticosteroids along with the long-acting beta-2 agonists. And step 4 is medium-dose inhaled corticosteroids along with the long-acting beta-2 agonists. Okay, so the step 1 is as and when there are symptoms, I am going to give a low-dose inhaled corticosteroids and long-acting beta-2 agonist, that is formoterol, as and when needed. So whenever there is wheeze, I am going to give this. Remaining days, I am not going to give. Step 2, I am going to give daily dose of inhaled corticosteroids. Daily, I am going to give low-dose inhaled corticosteroids. Step 3, I am going to add a long-acting beta-2 agonist along with the low-dose inhaled corticosteroids. And step 4, I am going to add a medium dose inhaled corticosteroid along with the long-acting beta-2 agonist. Okay, so where am I going to start with step 1? Where am I going to do step 2, step 3, step 4? If there are going to be symptoms less than twice a month, I am going to just give whenever there are symptoms. If there are going to be more than twice a month symptoms, I am going to give low dose inhaled corticosteroids. If I am going to have daily symptoms, most of the days I am going to give low dose inhaled corticosteroids plus LABA. And I am going to, if there is no response, I am going to go to step 4. If there is response after 3 months, I am going to taper down to step 2. Okay, so I will show you the other chart also. This is for children. Children also almost same. Step 1, I am going to give low dose inhaled corticosteroids along with salbutamol, but only difference in children is it's not a combination. I am going to give separately inhaled corticosteroid along with salbutamol. Step 2, I am going to start low dose inhaled corticosteroid on a daily basis. Step 3, I am going to start low dose inhaled corticosteroid along with long-acting beta-2 agonist. Step 3 is medium dose inhaled corticosteroids along with long-acting beta-2 agonist. And in children alone, still short-acting beta-2 agonist is the reliever of choice. But after 11 years, it's going to be, let me show, it's going to be low dose inhaled corticosteroids along with LABA. So low dose inhaled corticosteroids along with LABA, that is formoterol, is going to be the reliever. But in children, it's going to be salbutamol that is going to be the reliever. Okay. Avinash, you're able to pick up?
Yes, sir.
Can you repeat what you understood? I just want to know.
Okay, so for adults and children, the treatment is similar. In children, only difference is SABAs can also be used. It differs in that there are 4 steps basically. The first step is when there are symptoms only lesser or equal to twice in a month. In those cases, you just use ICS, low dose, whenever it's needed.
Okay.
Suppose the symptoms are more than twice a month, but it's not daily. In those cases, you would use ICS along with LABA.
Okay.
Step 3 would be when the symptoms are on most of the days, it's almost daily, and nocturnally the patient wakes up because of symptoms. In those cases, you give low dose ICS plus LABA. Sorry, in step 2, it's only ICS daily,
it's
which
not
you give.
LABA actually.
Yeah. In step 3, it's a combination of ICS and LABA. Step 4, you give medium dose ICS and LABA. If it's children, in step 1, it's not a combination of ICS and LABA. You give separately ICS as well as SABA. And the other steps are similar.
Okay, so long-acting beta-2 agonists as a reliever we don't use in children. That is the important point. So the basic, it's a stepwise approach. So remember, it's a stepwise approach. You start with low-dose inhaled corticosteroids. Initially, it is an intermittent, as and when required. So the step 1 is when there is monthly 1 or 2 episodes only. No need to give daily basis. You just give whenever needed low dose inhaled corticosteroids along with LABA, that is formoterol. And if the symptoms are going to be more, you start with low dose inhaled corticosteroids. So, and if the symptoms are going to be even more, that is daily symptoms, you add a LABA along with the low dose inhaled corticosteroids. And if still not responding, you go with the medium dose inhaled corticosteroid with LABA. Still not responding, you go to the high dose inhaled corticosteroid with the LABA. So just if you look into the chart, it will be easier for you. I will share the slides. That's it. Okay. And reviewing response every 3 months, you are going to see the patient and review and see whether you have to step up, you have to move to the next step or not. And if the patient is improving, good control, as I said, there is a criteria for good control. So nighttime no symptoms, daytime maximum it's not more than 2 times you are using reliever, then it's good control. So I'm going to step down the treatment. Okay. So how much am I going to step down? I'm going to step down 25 to 50% of the amount which I am going to have been giving before. So suppose I am giving 200 microgram of budicort, I am going to come down to 100 microgram of budesonide. So that's how I taper down every 3 months once based upon the control. But there is one thing that you keep on tapering, you cannot stop totally the steroids. So stopping inhaled corticosteroids is not recommended in adults with asthma because of risk of exacerbation. So asthma is something which you cannot cure it, and asthma is something where the treatment is going to stop. You have to give it on a lower dose, maximum lower dose, that is going to give a good control. But there is no concept of stopping inhaled corticosteroids in adults with asthma because of the risk of exacerbation. Okay. And there are non-pharmacological therapies which we have to do along with it. You have to cessation of smoking, physical activity, healthy diet, we said obesity, so weight reduction, and avoidance of occupational exposure. So you might have some smoke inhalation, occupational, and breathing exercises. So these are the non-pharmacological. And most important is avoidance of the allergens and air pollution. So you have to keep your home clean from mold and dust. Okay. And medications, sometimes NSAIDs can trigger, so those things also we need to take care. Okay. Any doubts? I think the main crux of treatment we have discussed. So any doubts in this, you can raise your hands. Okay, ma. So anytime you can text me also in WhatsApp. Okay. Okay. So we have to finish quickly. So it's not just treatment. Okay, you assess, you make a diagnosis, you are doing the stepwise treatment. It doesn't end with that. You need to be sure that the appropriate device has been given, especially if you are giving a meter dose inhaler. If you are giving a puff, I will show you the pictures. I will share you the pictures. Suppose you are giving an most of you have seen. Okay, suppose you are giving the puff meter dose inhaler. When you press, you have to inhale it correctly, and coordinating is very tough, and that's why it's always recommended to use a spacer. So always use a spacer when you are using a inhaler. Okay, so spacer is nothing but a chamber where whatever you press is going to be in the chamber. So you need not coordinate with your inspiration and expiration. Otherwise, it's going to be a real challenge in coordinating. So you press and you take a deep breath and take all the drug inside. Especially in children, it's going to be really tough. Whatever you press, it's going to go out and it's not going to respond. So technique is very important, and show the technique to the parents or the patient, and make sure they are doing the correct technique. So anytime when they come, always ask them to bring the spacer and mask with them. Okay. And poor adherence. So not taking the medication is also a very important cause. You say that you have to take 3 months, then after 3 months I am going to reduce down to 50%, then I'm going to reduce down to 50%, and then it's going to be a lifelong affair. You have to take it every day. So poor adherence is going to be a real problem. They're not going to take it for long. However you prescribe, they're going to stop it 50%, they're going to stop it, and they end up with so it's very important that you call them back, you follow them up, make sure that they are taking the regular medications. So main important is the asthma management education. So they should know to monitor their symptoms. They should know what is worsening of asthma. They should know how to step up their medications. So inhaled corticosteroids can be quadrupled in adults. So whatever the dose, suppose you're taking 100 mic, you make it 400. So you can quadruple the dose, and you should know when to add oral corticosteroids. So oral corticosteroids are going to reduce inflammation during the acute exacerbation. So there is a very important role for oral corticosteroids, so that the parent should know, or the patient should know when to take it. Okay, so this is the asthma action plan. So whenever your peak flow is reducing, you have to take the reliever, controller, and take prednisolone, and contact the doctor whenever they feel the worsening. Okay, so flaring up. So just I will touch upon the important flare-ups. So you need to understand what is mild to moderate and what is severe. Okay, mild to moderate is they will be able to talk, they are not agitated, they will maintain saturation, and their peak flow is more than 50%. But in severe, they will not be able to talk in sentence. They will talk in just words, and they are agitated, and their oxygen saturation is less than 90%. So you need to differentiate who are all mild to moderate and who are all severe. Simple as they are able to talk in words, they're able to talk in sentences, they're able to maintain saturation, and severe, they are not able to maintain saturation, they're using their accessory muscles, there is tachypnea, so that is severe exacerbation. Okay, and what is the immediate thing we should do is wait a minute, I'll bring my power plug. 1 minute. Okay, few more slides only, I will finish off. So make sure that you ask the patient to take 4 to 10 puffs of whatever salbutamol they are having every 20 minutes once for 1 hour, and they add ipratropium bromide, which is an anticholinergic, give oxygen, and start oral corticosteroid. So this is the same thing here. If it is critical, same, you continue with puffs of beta 2 agonist, but maybe the puffs may not work, you have to use nebulizer there, add ipratropium, give oxygen, and maybe since they are severe, you have to give IV corticosteroids. And one more important drug is magnesium sulfate. So in severe, we are going to give magnesium sulfate extra, you're going to give parenteral doses, and you are going to use nebulizer because they don't have the respiratory effort. But in mild or moderate, the same puffs can be used 4 to 10 puffs every 20 minutes once, along with the ipratropium. Give oxygen for both the patients, give oral corticosteroids, and here it's going to be IV corticosteroids and IV magnesium sulfate. Okay, and children, so just 2 slides. In children less than 5 years, so the problem with less than 5 years is you cannot do pulmonary function tests, so you're going to get only symptoms. So as said already, it's going to be cough, wheezing, fast breathing, and reduced activity, and a past family history of asthma. And since you don't have any objective way, the only objective way is to start a therapeutic trial. You give them the inhaler and see whether there is improvement. So that is the only objective way of diagnosing asthma. So you don't have any spirometry very easily available for less than 5 years. They don't cooperate with you. So the symptomatology will be almost same. cough, wheezing, difficult and fast breathing, reduced activity, and there will be a family history of atopy, and therapeutic trial only helps. And the most important problem with children less than 5 years is many viral infections present as wheezing. Many viral respiratory infection present as wheezing, they will be absolutely normal in between. So it's a very important differential diagnosis for asthma. So all that wheezing is not asthma in children. So many viral infection cause wheezing. So only when there is no cough and cold, still there is wheezing, there is a family history of asthma, they respond to bronchodilators, they are only probable cases of asthma. So you don't have any spirometry to prove that also. So viral infections have a very important differential diagnosis for asthma in children less than 5 years. So as the period progresses, the number of infections gets reduced. Okay. And one more important thing in children is you have to measure the height. So the inhaled corticosteroids, when if it is going to go for higher doses, it might affect the growth. Similarly, poorly controlled asthma. So you have not taken the treatment properly, it is going to affect the growth. The hypoxia is going to affect the growth. And in children, one more important is you definitely have to use spacer, and if less than 3 years, you need also to use a face mask. In addition, for the meter dose inhaler, you have to use the spacer and mask for less than 3 years. Okay, I think that's it. Preventions: avoid tobacco smoke, and promote breastfeeding, and avoid this NSAIDs during the first year of life. So this is the primary prevention of asthma. Okay. So any doubts? You can raise your hands. Any doubts? I'll share you the slide set. Sorry, pa. Okay, pa. Thank you very much, pa. I'll exit. Thank you. Thank you
Thank
very
you, sir.
much. Thank you.